Good afternoon, and welcome to the very last Webinar Wednesday of the 2017 series. We're excited to have over 120 registered attendees for today's webinar, which is eligible for 1 credit from the ACI. In honor of this being the last webinar for the 2017 series, we want to give one lucky attendee not only a Webinar Wednesday surprise pack, but also a $50 Amazon gift card for answering this week's trivia question. The question is, what is the first name of Scrooge from the Christmas Carol? Answer now using the question feature on your dashboard. While you're answering, I do want to invite everyone to join us for the 5th Annual Imaging Conference and Expo, also called ICE, which will be held February 16 through 18 at the M Resort Spa and Casino in Las Vegas, Nevada. The ICE conference will bring imaging service professionals from across the nation to Las Vegas for a 3-day conference of learning, networking, and the latest advances in imaging. Registration is now open. You can receive complimentary admission by using the code GOICE18. Again, that VIP code is GOICE18. Details can be found online along with the registration link at attendice.com. All right, let's see who this week's lucky winner is. Again, a reminder, not only will you receive a Webinar Wednesday surprise pack, but you're going to get a $50 Amazon gift card. And our winner is Manuel Vanderpool. Congratulations. We do want to thank all of our attendees, not only for this week, but over the year 2017, for tuning in and making Webinar Wednesday the most popular webinar series for the HTM industry. The correct answer to the trivia question was Ebenezer Scrooge. Now, Webinar Wednesday would like to thank our sponsor, Universal Medical. Universal Medical has nurtured a business philosophy founded on offering comprehensive nuclear medicine equipment services at a reduced price. You can visit uni-med.com for a complete list of products and services that Universal Medical can provide. Our presenter today is James McGee, founder of nuclearcardiologyreports.com. Unfortunately, Nik Iwaniw from Universal Medical is unable to join us, but thankfully Wayne Webster, principal at ProOtics Consulting, is stepping in to join us today. Wayne, you may begin whenever you're ready.
Thank you very much. Thanks everybody for coming to the webinar today. Thought it would be a good place to start to tell you a little bit about both of the companies that are here. Universal Medical Resources started over 20 years ago, and they did so for the purpose of providing maintenance services, parts, fully reconditioned and new nuclear medicine imaging equipment, and training for biomedical engineers and technicians. Today, Universal devotes itself specifically to the nuclear medicine marketplace, and it's this focus that has provided it a preeminent position in the nuclear medicine community. I'm joined today by Jim McGee, the founder and CEO of nuclearcardiologyreports.com. Jim, thanks for being with us today.
My pleasure, Wayne. Thanks for having me.
Jim, let's get right into it and really get right into this discussion. In recent years, with the expansion of quality-based programs and value-based medicine, there's a real need to measure whether we are meeting the standards set for the delivery of healthcare. Your company has something important to contribute in this area. Tell us a bit about what motivated you to expand beyond the technical director for nuclear cardiology and start your company.
Sure. So, yeah, I've been the ICANL technical director of the nuclear cardiology lab for the last 11 years. And the thing that motivated me to start nuclearcardiologyreports.com really were the ICANL and the American Society of Nuclear Cardiology, otherwise known as ASNC, reporting standards for nuclear cardiology. Some of us will remember back in 2010, Medicare cut reimbursement for nuclear cardiology by 30% in 1 year, in one fell swoop. And when that happened, the physicians that owned my practice decided to not pay for the reporting software that we had been using to create the final reports. And they just said, Jim, well, you can create the reports. So that's when I discovered that the ICANL reporting standards were really, really complex and difficult to comply with. So I started creating my own reports using Microsoft Word templates. And I discovered you can automate just about anything in Microsoft Word. You can have point and click graphical user interfaces, and that it's still maybe the best platform for creating sophisticated documents. So eventually, the physicians I worked with encouraged me to commercialize the software just because it was so simple and fast. And I wanted to commercialize it because I knew there must be a lot of other nuclear medicine techs out there like me who desperately needed something like this to comply with the guidelines that was affordable. And my friends at ICANL assured me that that was the case, that there were people who needed it, and that it is still the case. So anyway, I built the software from the ground up, revolving around the ICANL and the ASNC report standards. And that little picture there is a white paper that I published in 2012 when the 2012 ICANL standards came out. Just to make them clear. And on top, over the years, I've added error checking and corrective messaging and tried to make it really flexible for interpreting physicians. And, I've just been improving it every day through my own use and through the suggestion of my customers. I've got big customers like Houston Methodist Cardiology Associates, and I have little customers who are smaller practices who use a mobile service just one day a week. I do still run the nuclear lab. I like, working with patients and staying on top of things. And I do think nuclear cardiology is important. And that just kind of dovetails into this slide here. Nuclear cardiology, I think, is important because it monitors and evaluates coronary artery disease. So 25% of people in the US die from heart disease, and half of those deaths are directly attributable to coronary artery disease. And coronary artery disease is implicated in a lot of other heart disease as well. So despite everything we've heard about appropriate use criteria and prior authorizations and declining reimbursement, nuclear cardiology isn't going anywhere. It's now the case that most insurance companies require a nuclear stress test before they'll approve a cath, and also it's a practical necessity for many surgeries.
Jim, I understand the importance of nuclear cardiology, but what about the report? Why is the final report itself so important?
Right. Well, this is a quote taken from the Journal of Nuclear Cardiology, and I couldn't say it any better myself. So this says that the report from any testing facility to the requesting physician is the single most important part of the test, as it communicates the result of the test to the patient's healthcare provider, allowing them to act on the result and provide meaningful care. And that's just it. Every part of the test culminates in the final report, and it's the only thing that survives in the patient's medical record. Nobody's ever going to look at the images again. So a lot goes into the test, from the equipment manufacturers to the technicians at Universal Medical who tune the cameras properly, to the techs who do the test, to the interpreting physician. None of that matters if the results aren't communicated clearly and accurately, because oftentimes, months or years down the road, that's the only thing that the patient's healthcare providers are going to see. And the report has to mean the same thing to them as it did to the physician who created the final report. And that's known as the second interpretation, the interpretation of the report. So it has to be really accurate and really clear.
So Jim, this is why reporting is important, but what are compliant reports? And more specifically, why are compliant reports important?
So in order to be reimbursed by any insurance company or Medicare, nuclear labs have to be accredited, which means they get a stamp of approval from an agency who certifies that our nuclear labs are meeting their quality standards. United Healthcare first required this in 2008. The government started requiring it in 2012. There was an act passed called MIPA, and among other things, it required labs who do CT, MRI, or nuclear tests. They call that advanced diagnostic imaging. They require them to be fully accredited by an approved accreditation organization. And as we'll see, some of these accreditation organizations have really stringent requirements for our final reports, or we can't get that stamp of approval and we can't get reimbursed.
So, Jim, who grants the accreditation?
So there are 4 approved organizations now. There's the Joint Commission, or JCO. Hospitals generally use that. There's the American College of Radiology. Generally, imaging centers owned by radiologists will use them for accreditation. There's a newer company called RadSite that's not really widely used yet. And then there's the IAC Nuclear PET, who I've been referring to as ICANL, but actually they changed their name in 2012 to IAC Nuclear PET. So that's their real name. And most cardiology practices are accredited by IAC Nuclear PET, although I do have a number of customers who are accredited by the ACR also. But the IAC is the one that has the really stringent report requirements. The ACR is more concerned with camera image quality.
So what do we need to know about the IAC, Jim?
Well, they are a nonprofit corporation in Maryland. They've been around 25 years, and they accredit all kinds of labs. Everything you see on the slide there. They do the advanced diagnostic imaging, which is required by the government, nuclear, MRI, and CT, and then everything from cath labs to vein treatment clinics and dental CT.
Jim, who makes up the nuclear PET division of the IAC?
So the staff is generally comprised of nuclear medicine technologists with a good deal of experience, and then there's the board. And the board consists of leading physicians and techs from the organizations you see listed on the screen there. So the staff will sort of process our applications for accreditation, and then the board will meet once a month to review our application. Then they'll decide if our lab gets accredited or reaccredited, because we do have to reapply for accreditation every 3 years. So the board will say, accredited or not.
So I guess the big question for me is, how do departments go about getting accreditation, and who within the department is typically responsible for submitting the application?
Yeah, usually it would fall on the chief nuclear medicine technologist, who is known as the technical director of the IAC lab. However, practice managers and department administrators also bear some responsibility usually in making sure everything goes smoothly. The process basically consists of looking at the IAC standards, making sure your lab is following them. Then you create a policy and procedure manual, and then every 3 years you complete the online application. You upload all kinds of documents like certifications, protocols, final reports, and you usually mail in some case studies, the actual imaging data. So the thing is the technical director has to be given appropriate tools for the job, and because the report requirements are quite stringent, they need to be given a tool, and a lot of times they're not given the appropriate tool.
Interesting. So tell us, what happens if a nuclear medicine lab wasn't accredited, or just isn't accredited, or had a lapse in their accreditation?
Yeah, that's easy. You simply can't get reimbursed by anybody, insurance companies, state governments, the federal government. If your accreditation lapses, you can't get reimbursed, and if it gets reinstated, you can't get retroactively reimbursed for studies you did during the lapse. And non-compliant reports have always been the biggest cause of delayed accreditation with the IAC, and they still are. And I've had customers, small practices, who've lost over $100,000 in revenue due to a lapse related to compliant reports. That being said, I do want to say that the staff at the IAC is not out to get you or find something you're doing wrong or penalize you. Their goal is to educate us and make sure our labs are better and help us get accredited. They're super friendly. They're super helpful. Don't ever hesitate to call them with any question you have, even if you think it sounds kind of silly. They're on our side, and if you ever need any additional help with accreditation, you can contact me, and I'll do what I can to help you.
Jim, tell us a little about the current reporting standards for the IAC.
Right. Well, they've always been very complex. They did have new standards come out in March of this year, and they've added some new report requirements, and which I didn't think they would, and they've also clarified a lot of existing requirements. So just the reporting standards consists of 7 pages of fine print in the IAC standards. And they do monitor our report compliance. I mentioned earlier about the case studies every 3 years that we have to submit along with the reports. Also in the middle of the 3-year accreditation cycle, our report compliance is audited. Also new for 2017, the IAC is asking us to do quality improvement studies on report compliance on an ongoing basis. And also, you could be randomly audited or site visited at any time. Here are those 7 pages of fine print I mentioned before. Everything in yellow, highlighted in yellow, was highlighted by the IAC. That's what's new for 2017. So there is quite a bit of new requirements, but a lot of that is really clarification on the 2012 requirements. But that just goes to show how difficult they can be to understand. And also with the raw standards, they are categorized into categories, but it's not intuitively an obvious categorization, and the report requirements are sort of all over the place. And then finally, just one of their standards, 3.4A, recommends that we use a standardized report according to the ASNIC guidelines on standardized reporting. Easy enough to say, but that's 65 pages of fine print. So just understanding the reporting standards can become overwhelming, not to mention complying with them. And you're simply not going to create compliant reports by accident. You have to be very, very intentional about that.
So Jim, I guess it's reasonable to assume that every nuclear medicine practice is accredited, but do departments have any trouble achieving that accreditation?
Yeah, they do. The number one reason for accreditation problems with the IAC is final reports, like I've mentioned earlier. And this little visual here is a graphical representation of some data from a May 2017 study that was published in the Journal of Nuclear Cardiology. And what it means is under accreditation cycle, these are labs that have been through 3 accreditation cycles that they studied. And the first cycle means they were applying for the first time for accreditation. Second cycle means applying for reaccreditation for the first time. And third means applying for reaccreditation the second time. So as you can see, about 66% of labs had report deficiencies the first time. Then it went down to about 37% for their first reapplication. And then during their third cycle, they went back up to 44% of labs having report deficiency. So they do still struggle. And the article also mentioned that the things they struggle with most regarding reports are report timeliness. There's a 2-day turnaround time requirement for the IAC. Also properly describing perfusion defects, integrating the stress and imaging reports into one report. They need to be not 2 separate reports, but one. And finally, just documenting the date of the final report.
Interesting, Jim. Thanks for that. Let's ask another question here. How does a nuclear lab know if their reports are compliant with these IAC standards?
Yeah, it is very difficult, as we saw earlier. So we've created the definitive guide and checklist for IAC report requirements. So basically, we went through all those requirements with a fine-tooth comb and painstakingly categorized every report requirement into categories that sort of make sense, and also itemized each individual report requirement. And you can use this. Each requirement gets a checkbox like, yes, we comply with this, or no, we don't. Everything's clearly explained. It states what the current ASNIC terminology is for defects. They just came out with new standards in 2017, back in September. So this allows you to quickly and easily assess your compliance, and it gives you lots of room to make notes on anything you might need to approve. And you can download that for free on our website, nuclearcardiologyreports.com/WP for white paper. And the nuclearcardiologyreports.com, that's just all sort of one combined word that you can type into your browser. And here are the 9 categories that we broke the report requirements down into. This is in itself sort of an improvement over just the plain standards to help us understand things and quickly assess our compliance. This next slide shows the stress test results section of the white paper. And as you can see, there's a lot of requirements, and it's very easy to determine which you're complying with and which you're not. And there's lots of room to make notes on where you need to improve. The white paper is actually an 8.5 by 11 piece of paper, but I had to cut off the bottom there for this slide. The next slide shows the imaging findings requirements, and really this is only half of the imaging findings requirements. This is just perfusion. There's also wall motion defects. So as you can see, it shows the current ASNIC terminology for defects, size, severity, reversibility. It's very important to use the current standardized terminology just to cover yourself so that you are using the proper terminology. And if you don't say things in the proper way, patient care could be negatively affected down the road. But that being said, a lot of interpreting physicians really kind of like to say their things their own way. And they can be, very steadfast in those preferences, and they have very good reasons for saying things the way they want to. So reporting software should allow physicians to characterize abnormalities the way they want to, maybe in a more clinical fashion in the impression section, while maintaining compliance with the ASNIC standards in the imaging findings section.
Thanks, Jim. That's interesting. If a lab discovers their reports are not compliant, what kind of solutions work and what kind of solutions don't work?
Sure. So, traditional report creation methods, voice dictation is just not going to work to be IAC compliant. There's no physician that could really meet every single requirement using voice dictation. It would just take too long. A lot of people do use non-automated text templates, kind of fill in the blank, but that's going to take 10, 15 minutes a report to fill in everything that's required. And inevitably, there's going to be errors because proofreading is manual. You can pay your EHR vendor quite a bit usually to customize templates for you for nuclear reports, but they're going to want you to tell them how to do it, and you don't really want to be spending your time reinventing the wheel. Also, there's usually not error checking algorithms in there. So EHRs are great at encounter notes and storing and transmitting nuclear reports, but the vast majority simply can't create an IAC nuclear report. So what you really need is an automated templated reporting software, otherwise known as structured or standardized reporting software. You want something that's specifically built for IAC compliance, and you want comprehensive error checking to make sure that it's compliant. And your reporting software should really make it just about impossible to create a non-compliant report. So if you're evaluating software packages, just make sure that they are compliant, because some of them are not, and you can use our guide and checklist to sort of evaluate different software packages. This next slide is sort of from the end of our white paper, where we show how our software meets all these requirements. So I'm not going to bore everybody by going through everything. I'll just kind of try to hit the highlights. Section 1, facility information. In addition to your contact info, you want your logo and your brand to be properly represented. It should have good visual design and be easy to read. Because again, this is the only thing that the physicians who are sending business your way are ever going to see about your lab. That's all they really know about your lab. The demographics section, height, weight, and BMI, that's a new requirement by the IAC for 2017. And also, I want to say that your indications variables should be designed to easily demonstrate appropriate use criteria compliance, because that's getting more important all the time. Naming your procedures and describing them, this is actually pretty important, because everything on the report that shows how you did the test has to match your IAC policy and procedure manual. Otherwise, you may find yourself in the position of explaining to them why your report says you did things differently than your policy and procedure manual. So things like waiting times between injection and imaging, the exact kind of images taken, like planars, did you do gated, non-gated, did you use attenuation correction, did you do prone imaging? And also just to have, it's important that every little detail is documented, because if you don't say you injected Sestamib intravenously, Medicare can actually recover your prior reimbursement for a detail like that, even though we all know you can't inject Sestamib any other way, like intramuscularly or subcutaneously. So those little details are important. Stress test requirements. Again, there's a ton of things you have to include in there, so you're going to want your software to error check that it's all included. Also, I want to say for these two sections 4 and 5, it's really important that the stress and imaging report should be all in one report. That's a requirement, and it's a bit of an art to get all this information on one page, but it really should be done. Reports, we feel very strongly, should be 1 page long for 2 reasons. Referring physicians don't like to have to work to ferret out the relevant findings on a wordy, long report. Also, the other reason is when you transmit the report to another physician's office, their staff can separate multiple page reports, and the physician can end up being sort of misled by missing pages. Section 5, like I mentioned, the imaging findings should use the latest 2017 ASNC terminology. And for creating this, you're going to want your user interface to be fast, simple, and uncomplicated. A lot of user interfaces in this industry are quite complex, and it's kind of hard to get your bearings looking at the screens. Our template reporting system, for normal images, a physician chooses the EF, and if there's no previous, they click no previous study, and they're done. and also the software should have error checking for the interpreting physician, just to make sure that they can kind of move quickly and not do a lot of extensive proofreading once they're done. So impression section, a new requirement for 2017 is that we have 2 concise summaries for the study. And when I say concise, I mean 1 or 2 words. So a concise summary for perfusion and a concise summary for LV function. So things like normal perfusion, abnormal perfusion, normal LV function, abnormal LV function. And also, like I've mentioned previously, physicians should have a lot of flexibility in the impression section. Otherwise, it's going to be hard to satisfy multiple interpreting physicians while still being compliant. So they should be able to characterize perfusion defects however they want in the impression. Instead of saying partially reversible, which is the ASNC terminology, they may want to say infarct with peri-infarct ischemia. Also, they should be able to have drop downs populated with their own custom sentences, because a lot of times they have specific phrases they want to use, and they know their audience for the report better than we do. On the next slide, for report finalization, just a little thing, electronic signature should be time date stamped. And for turnaround, report turnaround, there is a 2-day requirement from the IAC. So final reports have to be transmitted 2 days after the study date, but really the final report should be available immediately after image interpretation. It should be already checked for errors by sophisticated algorithms. There should be no need for extensive proofing on the interpreting physician's part. He or she should just be able to give it a once over and sign it. And that makes things like same-day office visits, sending patients right to the cath lab, or quick surgery clearances just really easy in your office or department. And if it's not immediate, sometimes you might end up with a preliminary report that someone might need immediately. So now you've got 2 reports for the same study, and if there are discrepancies between those 2, it just creates a lot of confusion in the medical record. And then the last section here, record keeping. Again, just real quick, your report should be easy to amend. And I did want to mention again, the final report we feel should be 1 page, just to be clear and concise, and to avoid getting pages separated by other people's offices.
Great, Jim. I appreciate that overview. Let's ask you another question here, which is more practical in nature, I expect. What should someone expect to pay for a package that solves the problems of compliance with the IAC standard? Is it very costly?
Yeah, some packages can be very costly. A lot of companies will charge $20,000 or $60,000 up front, and monthly fees starting at $400 a user. We offer volume-based pricing. Our vision is that every single nuclear cardiology lab will have exceptional reports fast and easy. So we offer very significant discounts for smaller labs. So we ask you how many reports you need, and per week or per month or whatever. And the smallest increment that we start at is 5 studies per week, for practices that just use a mobile service, maybe once a week. So you can generate an instant quote online. Just go to nuclearcardiologyreports.com/price, and you will get an exact quote for your lab instantly emailed to you. It is most definitely affordable for every lab. It's nowhere near as expensive as mentioned at the top of the slide, and it's definitely a budget-friendly solution.
Interesting. So how does a lab go about determining if this solution will work for them? Is there a way for them to do that easily without getting too involved?
Sure. So there's 3 steps to implement our package, which is called the template reporting system. You evaluate it, then we customize it for you, then you start using it. So to evaluate it, you can go to our homepage. There's a big green button that you can't miss that says create a report in 5 minutes, and you can download a quick start demo template. There's video instructions on how to use it. The only system requirement is a Windows PC with Word 2007 or newer. Then there's the quote again. And then if you think you like it, you can schedule a live remote demo. Those usually take about an hour, and you'll see exactly how everything works. A decision-making interpreting physician should attend the live remote demo. And there's also, we have a video training center on the website. You can watch those video tutorials, and it'll show you how it all works.
Great. Jim, every department is different. Certainly from your description, they are, and I suspect that that's the case. So what is needed for customization? You mentioned customization in this slide and in other parts of your discussion. What is actually needed to do that?
Right, so every department is different, but we've kind of got the process pretty streamlined. What we need is either a quick conversation with your chief tech about your protocols, or you can just email us your protocols, and we can customize it according to that. We also need letterhead or logo, but sometimes people don't have that handy, and we can just get the logo off your website and create letterhead for you. A list of your personnel. We need the interpreting physician signatures and the passwords they want to use to sign. A list of the custom sentences. Sometimes it's hard to, cardiologists are very busy, so it can be hard to get those custom sentences from them. But I've talked to physicians at night while they're watching TV, and they just give me the sentences, and those were actually some of the best sentences I've ever heard. Also, if you want any other custom variables, just give us a list, and we'll create drop downs for that. But anyway, all said, that can be gathered in the course of a day. And if we need to update things, if you want additions, more custom sentences at a later date, we can do that too. So that's what's required.
Good. Jim, we all know that any new software we buy claims to be easy to implement. What should a user expect with your software?
Yep, fair enough. And yeah, that's why there are so many non-compliant reports being generated, is because changing the way you create nuclear cardiology reports sounds like a big task. I think a lot of people think it would be too much work, take too much time, effort, concentration. But what should a user expect? Basically, after we customize the templates, we do a live training session where we answer your questions. And really, after people have seen the live demo, that training session usually lasts maybe 30 minutes to an hour because everything is so intuitive. And then there are also custom, or rather concise video tutorials online to, in case you have a question. There's also phone, text, email, screen sharing support. And if you use it for 30 days and you decide you don't like it, we'll give you your license fee back, and nobody's ever taken us up on that. Also related to implementation, I have a testimonial here from Shaniqua Anderson. She's a medical assistant in New York. She enters the demographics and stress test at her practice. And she says the template reporting system looked great, but we had some concerns about if we could easily implement it. In the beginning, I was a little apprehensive about using it, but once I gave it a try, I'm all in. I find the templates to be very helpful and easy to use. It's really cool. The support and service has been great, and we're all really happy with the software. Thanks a million. And this next slide is a testimonial from an interpreting physician, Mark Goldberg. It's fast and super easy to use once you've done about 7 reports. Quickly produces complete concise, ICANL compliant reports that are free from errors. Very short learning curve.
So that's good to know. Tell us what kind of results can labs expect after they perform the implementation of the software?
Yeah, I think probably the biggest one is peace of mind, because everything is error checked as you create the report for absolute compliance with the standards. Also checked for any errors or omissions or logical inconsistencies, and you get a success message when everything is compliant and complete and consistent. So, you know, that enables you to just really quickly create your reports without worrying if you forgot something. And there's a lot that, you know, you could potentially forget, you know, from the standards. And also, it's just simple and fast. It takes about 2 to 2.5 minutes for a tech, about 30 seconds for normal reports for physicians. It's basically they click the EF and then no previous if there is no previous. And another sort of operational result is your multiple interpreting physicians will be happy because they can all say things their own way due to the flexibility. And then the immediate report turnaround really just kind of, it just makes things easier for the way your cardiology practice or department functions, because you know, it's the report is ready right away, and physicians don't have to you know, concentrate on the report for a little while, then something else, and come back to the report to correct the transcriptionist's errors. And then finally, just the report quality. Again, comprehensive, clear, concise, all on one page. There's a visual hierarchy to things where you can easily find what you want. The design kind of sets your practice apart. As you can see in the middle of that report, there's a exercise test summary section that gets automatically generated, which is nice for your referring physicians because they don't want to look at every single IAC required stress test piece of data. And again, the defects can be described clinically, unlimited custom sentences, and finally, the spelling, the grammar, the punctuation, the spaces between words and the spaces between sentences, that's all perfect as far as I know at this point. So that's about it.
Jim, thank you very much. That was very informative, and I think we have a few.
Hi, Wayne. Yes, we do. We had a couple of questions from attendees that came in. So what I'm going to do is ask the questions open-ended to both of you. Whomever needs to chime in, please do to answer the question. But I do want to take just a moment to remind attendees you can still submit questions for this live Q&A portion. Use the question feature on your webinar dashboard, and we're going to get through as many as we can. Any that we cannot work into the next 15 minutes, we're going to send to the UMRI crew afterwards for Universal Medical to answer offline. But with that said, the first question is, do you offer polar plots?
No, we don't. That would make the report more than one page, and that's a strong part of our philosophy. Also, we kind of feel that nobody really finds them valuable or useful besides nuclear cardiologists, and they're the ones creating the report, not interpreting it. And the other thing is the way, if you stick with the ASNC terminology in the imaging findings sections for size, severity, reversibility, and segments, you can basically picture what the polar plot would look like anyway, but mostly it's to keep them down to one page.
Great. This next question is from an attendee who is currently using CardioWriter, and they ask, how difficult will it be for us to switch?
Yep. So yeah, CardioWriter, I have a number of clients who switched from that. That's a piece of software that Cardinal Health used to put out. It's no longer being supported, but it's not very hard to switch. We could have you switched over by this time next week. Like I said, it takes about a day to get the information to customize, and then a training session, and then you start using it. And after people start using it, I generally get about maybe 4 emails or phone calls with questions. And compared to CardioWriter, our customers, techs and physicians, find it easier to use and faster, and they find that the final report is much better.
Is this program a cloud app or something we install on our network?
Right, so it's neither. Like I mentioned, I think at the beginning, I started by automating Microsoft Word templates. And in the end, I stuck with that platform. I did think about making it a cloud app for a while, but those tend to be a little inflexible because you have to serve the same interface to all of your customers. So the ability to customize is a little bit limited. Plus, it's very hard to create a final report that looks really, really nice from a formatting perspective on a web app. Most of the platforms just don't have enough formatting options. So, in the end, I stuck with Word, and I do still think it's the best platform for creating really nice documents. And then, in terms of installing something on your server, you don't have to do that. Everything happens within the Microsoft Word programming as you're creating the report. So that's nice because you don't have to install an application and database on your local servers that break down and require maintenance and stuff like that, or involve your IT department. And a lot of those local applications end up exporting the data to Word anyway to make it look nice. So we just kind of cut out the middleman, and Word is more than adequate to have good sentence generation algorithms and error checking algorithms and things like that. So it's neither. It is a collection of Word templates.
All right, another question from an attendee. This one might be a little open-ended. How much time do reports take?
Once for a technologist, if the technologist is doing the demographics and stress test data, it generally takes them about 2 to 2.5 minutes per report once they get used to it. There is a stress worksheet that gets filled out with paper and pen during the stress test, and that worksheet is very closely matched to the way that you enter the stress test data. So about 2.5 minutes for a tech. For physicians, for normal reports, start to finish, it's about 30 seconds. They open the report, they look at the demographics and stress test data, they create the normal report and sign it. That really takes them about 30 seconds. It takes them about a minute for abnormal reports in general. But then the thing is once they're done with that, the final report is complete. Everything's been error checked. They don't need to, go through it with a fine-tooth comb. They just electronically sign it, and now your final report is done. And you just save it as a PDF and upload it into your EHR.
I have an attendee that would like to know, can your template be copied into Epic EMR?
Well, I mean, you couldn't sort of import the document and complete it in Epic. No, you complete it in Microsoft Word, but you can, from Microsoft Word. The way it works is you save it. There's an option to save the report as a PDF. and then you upload it into Epic or scan it into Epic. And, you know, I mean, certainly everybody's using an EHR right now. That's your central repository. And, you know, uploading or scanning a PDF into, or scanning a piece of paper into an EHR is something that everybody's doing. So usually, you know, there's a medical assistant somewhere who knows how to do this for your EHR, and it's basically you know, not a difficult task. It's something that's already being done. You just upload it and label it.
Perfect. Thank you very much. I want to give a big thank you to Wayne and Jim, our presenters today, for a great webinar, and also another thank you to our sponsor, Universal Medical. To learn more about Universal Medical, please visit their website, uni-med.com. One lucky attendee today will have another opportunity to win an Amazon gift card for completing the post-webinar survey. The survey is going to appear on your screen shortly. You must complete the survey to obtain your certificate of attendance, but if you do not see the survey, please email us at webinar@mdpublishing.com. I want to remind everyone that Webinar Wednesday for 2017 has wrapped up this afternoon, but we will be back with a brand new series for 2018 that is kicking off late January. Stay tuned for more information and our calendar to be updated on onetechnation.com/webinars. Until then, happy holidays, Merry Christmas, enjoy the rest of your week, and we will see you back in 2018.